Hey guys, welcome back. This is the part 2 of our video on shock, where we're going to talk about strictly the phases of shock. Review the first video, part 1, which tells about define shock and also tells us about the different types of shock. Alright, so there are different phases of shock. So phases of shock or progression. So in video 1 we looked at definition and the types of shock. So the phases or stages of shock. The first one, there are 3. We have what we call the non-progressive stage of shock. Okay, and then 2, we have what we call, this is also called the compensatory phase, also called the compensated phase of shock. 2, we get to the second phase is what we call the progressive phase of shock, and then 3, we get into the irreversible phase of shock. All right. So this is quite very easy. So usually when someone is in shock, the body tries to bring in compensatory mechanisms that can help to restore that person's blood pressure or perfusion pressure, which is the MAP, back to normal, okay, or to recover you from shock. But in case these mechanisms fail, so someone tends to move into progressive shock. In progressive shock, if you intervene, okay, the mechanism are failed in non-progressive. In progressive shock, shock is progressing, undergoes a vicious cycle, as we shall see. So as it is progressing, if you intervene with therapy or any form of treatment, depending on the type of shock, you could have a possibility of recovering this person from shock. Okay. Whereas in irreversible, at this stage, irrespective of the type of treatment you give, the chance of recovery from shock is actually very, very minimal. Okay. So usually someone usually progresses through these phases of shock in case you don't intervene or you don't give any treatment, or in case maybe your treatment is not effective, so the person can actually progress into these phases of shock. So in non-progressive shock, non-progressive stage, so in this non-progressive stage, what happens? What we need to know actually, so as soon as someone, depending on the type, hypovolemic or, as we talked about, so let's try and use hypovolemic shock. So if you've had a decrease, maybe you're losing a lot of blood, so the body tries to bring in different mechanisms, okay, that will try to do what? Different mechanisms that try to compensate for the shock, okay. So what are those mechanisms? Okay, so the first thing, usually when your blood pressure falls, we have some, let me draw here, we have what we call baroreceptors. Okay, let me just use this diagram to try and illustrate. Okay, so we have baroreceptors. They're usually found at the aortic arch. Okay, so let me just use this is the aorta. Let me just use this to illustrate, to be maybe our aortic arch. Okay, a curve, the arch around here. So these baroreceptors are found around the aortic arch. We also have baroreceptors. Let me use this illustrate to be in our carotid. Okay, you saw the bifurcation of the carotids. You have other baroreceptors. Okay, so these two receptors, so the receptors from the bifurcation of the carotid, usually send they are innervated by nerves called the hearing nerves. Okay, the hearing nerves, which different hearing nerves, they join into the glossopharyngeal nerve, the cranial nerve number 9. Okay, the cranial nerve number 9. Whereas these ones at the aortic arch, these ones usually come from the cranial nerve number 10, which is the vagus nerve. So both of these nerves, usually they detect these baroreceptors that are found here. They detect the fall in the blood pressure. Okay, and then these usually send their impulses to these centers. Okay, we have two centers at the nucleus tractus solitarius. Nucleus tractus solitarius. So this nucleus tractus solitarius is usually found at the lower portion of the pons and to get close to the medulla. So usually around the reticular substance. Okay. So this nucleus tractus solitarius, this has integrative centers. We have two centers here. We have, we have what we call a cardio-inhibitory center, a cardio-acceleratory center. So these form the cardiac, okay, there's what we call the cardiac center, okay, and then we have the vasomotor center, okay, the vasomotor center. This vasomotor center has a vasodilatory portion and a vasodilator and vasoconstrictor portion. Okay, so we're going to see the effects. So when there is a fall in the blood pressure, okay, this is detected by these baroreceptors, which are found at the aortic arch and the carotid sinus. These send information through the glossopharyngeal nerve, so of course the herrings which join the glossopharyngeal nerve and the vagus nerve, and send that information to this nucleus tractus solitarius, okay, which has different centers as we've already talked about. So these, what do? So this information that's coming saying there is a decrease in the blood pressure is going to shut off the cardio inhibitory and the vasodilatory centers, okay. So and what is it going to cause? So the cardioacceleratory and vasoconstrictor centers are activated, okay. So and what do they bring about? One, you're going to see the cardioacceleratory center that is going to send this information, okay, send this information to the sinoatrial node, okay, and then telling the heart, please increase the firing rate, okay. So and then also the AV node to increase the firing rate. And when you increase the firing rate, what happens? Heart rate is going to go high, okay, and then also since heart rate is high, cardiac output will increase, and when cardiac output is high, your mean arterial pressure is back up. So the first response that we get, compensatory response, is this baroreceptor reflex, okay. Then the other thing is this sympathetic input comes also, especially from the vasodilatory area, okay, and so rather vasoconstrictor area, sorry. So this is going to come to the venous side and also cross over to the arterial side and bring about two effects. We have venous side, venoconstriction, arteriolar side to cause arterial constriction. So how do they play a role to compensate for this decrease in the blood pressure? So this venoconstriction, what does it do? When you constrict these vessels, okay, you're going to increase the venous return, okay. So as you increase the venous return, amount of blood returning to the heart, by Frank Starling, your cardiac output increases, okay. So increase in venous return, of course, you're increasing your stroke volume, okay, and then cardiac output is increased, and then obviously your mean arterial pressure is restored back to normal. That's for venoconstriction. Then when you cause arterial constriction, what happens? Constriction of the arterioles, okay, this increases the total peripheral resistance. Increase in the total peripheral resistance, what does it cause? When you increase the total peripheral resistance, your mean arterial pressure is restored back to normal, okay. So the other mechanisms, let's continue and look at them. So you see there's this sympathetic input. This sympathetic input also does something. So these impulses also are fired upwards, okay, to the brain, okay. This is the hypothalamus, okay, fired to the hypothalamus, which hypothalamus has neural cells that are code for the thirst center. And then so we have the thirst center is stimulated, and what are we telling this man? Please, our volume has decreased. Increase, we need intake, okay. So we increase the thirst, okay. Someone gets the thirst and then starts asking for water, wants to take water, okay. That's why the response, these patients, when they're in hypovolemic shock, as time progresses by, they're going to start asking you for water, okay. Doctor, I'm thirsty, you know, nurse, I am thirsty, and the rest. So this is the mechanism, cause of activity of the thirst center. But also, so here we can add activation of the thirst center, okay. So after that, then these impulses also from the detection of the osmolarity and things like that, you're going to have an input to the posterior hypothalamus. And what is it going to cause? It's going to cause the release of ADH, antidiuretic hormone, or which is also called vasopressin, okay. So that vasopressin can do vasopressin, constriction of these vessels, especially with the arterioles, and contribute to the increase in the total peripheral resistance. But also we shall see the effect of ADH within the kidney, okay. So what other thing does this sympathetic input also runs down to the adrenal medulla, okay. So this is our adrenal, to the adrenal medulla, okay, adrenal medulla. So it goes to the adrenal medulla and causes the medulla to release epinephrine, okay. So these chromaffin cells that are found within the adrenal medulla are more like postganglionic cells of the sympathetic nervous system. So what are we doing? We are augmenting the sympathetic activity, Okay, these can actually have an effect, bring about sympathetic effect to the heart and also to the vessels, bring about the same effects as we had already looked at. So, but also this sympathetic input comes down to the kidney. Okay, so if this is our kidney, so comes down to the vessels of the kidney. Okay, we have the afferent and efferent arterial system. Okay, and then we have our loop here, rather our nephron. Okay, we just do like this. So we have our nephron here, of course, and then down into the collecting duct. Okay, yeah. So now what happens? This sympathetic activity comes here and causes, causes vasoconstriction of these afferent arterial vessels. When you vasoconstrict these afferent arterial vessels, what happens? You are decreasing the volume of blood that is reaching into the glomerulus. Okay, filtration volume decreases, so you get a decrease in your glomerular filtration rate. Definitely, the amount of filtrate is actually decreased. Okay, and so. And even you get a total decrease in the amount of sodium within the filtrate. So we have different cells at the juxtaglomerular apparatus, okay, which cells are called the macular denser cells. What do? These ones detect this decrease, okay, this decrease in the sodium, okay, that is coming along with the filtrate due to these effects in decrease in this blood pressure, okay. And what does it cause? It's going to cause the release of renin. Okay, so it's going to release renin. So this release renin. Okay, and what does renin do? Renin goes to the liver. Okay, this is our liver, and causes the liver to convert this angiotensinogen tensinogen. Okay, angiotensinogen to angiotensin 1. Okay, so this angiotensin 1 now moves to the lungs. Okay, moves to the lungs, where we find angiotensin converting enzyme that's going to convert this angiotensin 1 to angiotensin 2. Okay, so this angiotensin 2 brings about effects. Angiotensin 2 1, it's going to move to the adrenal cortex. Okay, this adrenal cortex, this time it is the cortex. Okay, this time it is the cortex. So when it moves to the adrenal cortex, what does it do? Especially the first layer, the glomerulosa, zona glomerulosa, it's going to cause this to release what we call a hormone aldosterone. Okay, so when aldosterone is released, what happens? This aldosterone is going to come and then act on the kidney nephrons, okay, around this portion here. And what does it do? It increases the expression of the sodium channels so that we resolve a lot of sodium, okay, of course coupled with the excretion of potassium and protons. So, but mainly keeps retaining, okay, retaining sodium in circulation. So if these are our peritubular capillaries, so we get a lot of sodium that is retained within circulation. Okay, but also remember the effect of ADH. This ADH now comes and also acts on these collecting tubules and the distal collecting tubule. And what does it cause? It causes increased expression of the water channels, which are the aquaporins too, to cause increased reabsorption of water. So eventually, what are we doing? We are increasing the blood volume. So when you have an increase in your blood volume here, when you increase your blood volume, definitely you're going to increase your venous return. When you increase your venous return, and then you're going to increase the end diastolic volume, increasing the stroke volume. And when you increase the stroke volume, cardiac output increases and mean arterial pressure is restored back to normal. Okay, so some of the mechanisms here, you see, we talked about the ADH response. Okay, we've talked about the role of epinephrine. Okay, we've talked about the renin, angiotensin, aldosterone system. Okay, so let me see, 1, 2, 3, 4, 5, 6, 7. Okay, so look here, there are other mechanisms. There is also, when you look at this, there is what we call the fluid capillary fluid shifts. Capillary fluid shifts. Okay. So what happens here when you have if this is your vessel, okay, especially at the level of the capillary, then you're having a very big decrease in the volume here because of hemorrhage. Okay. So what happens, or maybe plasma losses, you find the capillary hydrostatic pressure here falls. When the capillary hydrostatic pressure falls, which means the pressures in the interstitium are much higher than the pressures in the what? In the intravascular. So these favor fluid so this favor fluid to move to shift from the interstitium into the capillary. Okay, so this fluid that returns to the capillary, especially on the venous end of the capillary, this will increase the blood volume. Increase the blood volume, increase venous return, and by Frank Starling, cardiac output increases and mean arterial pressure is restored back to normal. Okay, so there are other mechanisms. You see this baroreceptor reflex. This sometimes is augmented. This process of shock is taking place. There are other receptors which are called chemoreceptors. Okay, so when you're in a state of shock, okay, and there's a tendency to decrease amount of blood that is reaching the vessels, oxygen amount decreases. So we also have chemoreceptors. We have peripheral and central chemoreceptors. So there are some chemoreceptors that are found still around the carotid body and then the carotid sinus. These fire through the same nerves, okay? And when they fire through the same nerves, they affect still the sympathetic effect. But also, because of the input into they contribute, this is the input into the respiratory center. What is going to happen? You're going to have a tendency to increase in your rate of respiration. So you can take in more and more oxygen to compensate for the hypoxia. Okay. So, but they also usually, as blood pressures keep falling, okay, so this baroreceptor reflex plays a role. Usually tends to keep your blood pressures routinely maybe within 80 to 100 millimeters of mercury, okay. But when you get starting maybe 180 to 100, as your blood pressures start falling, okay, lower and lower, you recruit the chemoreceptors, and then eventually, if your blood pressures have fallen significantly to around 50 millimeters of mercury, then you recruit the CNS ischemic response. So this response here is quite very important because when it is recruited, what does it do? It is going to bring a very massive sympathetic input. Okay, so this CNS ischemic, which means that usually the CNS center, this control center, starts experiencing ischemic changes, and so it realizes that, well, we are getting depleted of blood. What does it do? It is going to increase to its effect, the sympathetic effect, so we can have full-blown sympathetic effects to try and raise the blood pressure back to normal. But what usually happens, if this fails usually, then it will be very hard to recruit any more sympathetic response. Okay, and that's why we tend to call this the last ditch stand. Okay, because this is the last thing you can need. This is the last thing that can help you to survive. Okay, because you need that blown sympathetic activity, which is usually as a result of this CNS ischemic response. So you see about 10 responses that play a role in this compensated shock. Okay, so what happens if this shock becomes progressive? Okay, you don't get any response. Let's see what happens. So during this progressive stage of shock, what happens? Okay, usually we said in this phase of shock, when you get into therapy, when you get assistance, when the body gets assistance, maybe from treatment or therapy, there's a chance that you will actually do what? You will recover from the shock. But if you do not recover from the shock, what usually happens? Okay, let's have a look at this. I'll use this to illustrate. Okay, where this is our heart, and then this is our circulatory or the vascular system. So usually here you find that remember, when the tissues usually, as we had vasoconstriction, okay, sometimes when you have vasoconstriction, this limits blood supply to some organs, so that we maintain, so that we keep the blood supply to vital organs like the brain. So blood supply, when you induce early phases of shock, blood supply to the parts like the GIT, for example, the skin, decreases, okay, so that you get blood, a little blood available, conserved for the brain and the heart, okay. So when you're in a state of progressive shock, this tends to be, we call it a vicious cycle. You get a pattern that is repeating on and on of shock. What happens? You see, under normal circumstances, when you have in metabolism, glucose undergoes glycolysis to form pyruvate, okay? And obviously pyruvate moves to the TCA to give us and generates a lot of ATP through this cycle, okay? But what happens when there is, during this phase of shock, this hypoxia, okay? The biggest problem here is actually this progressive hypoxia that is taking place, okay? So this hypoxia, what does it cause? This hypoxia here, due to makes now this pyruvate will be shunted into anaerobic respiration, and then we form what you call the lactic acid, okay, due to the anaerobic respiration. So now this acid starts to bring about different changes within the tissue, okay. Remember, this lactic acid is it can be a vasodilator, okay. So it will bring about local vasodilatation of vessels, okay. So because of this local vasodilatation, these tissues here, for example, the GIT cells, they had compromised for the blood. They had compromised so that the heart and brain can have blood. But as shock progresses, they're also going to start rioting. They're going to say, no, we cannot handle it anymore. We need some blood also, okay? So then you're going to, because of this accumulation of some of these acids, and maybe carbon dioxide and this, they're going to cause local vasodilatation. So they can also want to receive some blood, okay? But this only, well, first of all, there is already little blood in circulation, okay? Because of you've lost maybe in hypovolemia. So the GIT and these other structures are starting to also want some, because they are dying out. They cannot sustain it for long. So there is local vasodilatation. So at the level of the vessels, we are going to see that now we are seeing the different changes that are occurring at the level of the vessels, okay? There's what we call this local vasodilatation, okay? So at this local vasodilatation, we shall see the vessels, we shall see at the level of the tissues what is occurring, okay? So there's local vasodilatation. On top of local vasodilatation, this lactic acid has a tendency to cause the blood cells to start aggregating together, okay? The blood cells start aggregating because of this extensive acid that is in circulation. The blood cells start aggregating together, okay? So they form sort of this kind of, we call it a sludge of blood. A sludge of blood, okay? So this sludging of blood, when it becomes excessively, it causes now blockage of these blood vessels. So we get blockage of small blood vessels. So you see, now we are blocking vessels. We are now limiting more and more perfusion of the tissues, okay? So because of this local sludging of blood and these vessels are starting to block, something happens. The tissues now, they are limited in the amount of oxygen and nutrients that they are receiving, okay? So these tissues are starting to undergo more and more hypoxia. Remember, for example, like the GIT cells, the GIT tissue has different bacteria. Because of the progressive hypoxia, these bacteria are going to die out. So especially the dead gram-negative bacteria, okay? The dead gram-negative bacteria. What do? They will produce endotoxins, okay? So they produce endotoxins, these dead bacteria. And these endotoxins are actually damaging, okay? They keep damaging the tissues. So you're going to start having tissue damage here because of this process, okay? But you're going to see also that when these endotoxins, okay, maybe I'm going to tell you. The second thing, the ischemic changes, okay? Ischemia to the tissues, okay? Makes the tissue to start releasing some substances like histamine, okay? Histamine. And remember, we already said histamine is a vasodilator, okay? It is decreasing more and more, causing local vasodilatation. Also think about it like this. Local vasodilatation, we say to decrease the total peripheral resistance. Definitely, the mean arterial pressure goes down. So you're saying that instead of recovering the mean arterial pressure, we are depressing it more and more because of these mechanisms that are taking place. Okay, so you're seeing this now. This acid and these endotoxins, they can actually spill into blood, into the circulation. When they spill into circulation, of course they will reach the myocardial cells. When they reach the myocardial cells, they are damaging to the cells. Okay, they are damaging to those cells. What is going to happen to the heart? You're going to have what you call the heart is going to be depressed. So the other response is actually you get a cardiac depression. Okay, because of this accumulation of these endotoxins. Okay, but also the accumulation of lactic acid is going to cause cardiac depression. Okay, but remember, this circulation, this blood actually also moves in the vessels and reaches to the higher centers. Okay, especially the brain. Okay, so it reaches the brain, especially those control centers like we had seen. What is going to happen? These centers are undergoing ischemia. Okay, they're undergoing ischemia. We have a vasomotor center, cardiac center. They're undergoing ischemia. So when they undergo ischemia, they cannot perform their activity. So the cells start to die out. So these ischemic changes will cause what you call a vasomotor failure, because we lose the input of the sympathetic nervous system to the vessels. So this vasomotor failure, what is it going to cause? Vasomotor failure, like we already saw in our previous video, vasomotor failure will cause local vasodilatation. You lose the vasomotor tone. Local vasodilatation will decrease the total peripheral resistance, and that also will decrease the mean arterial pressure. So you, instead of restoring, you're finding now we are getting more and more depression of the what? More and more depression of our mean arterial pressure. Okay, so you see this pattern. So remember, the heart is failing. Okay, the amount of blood in circulation has decreased. These mechanisms are also making the heart, so if the heart is failing, it cannot pump enough blood out. Okay, so the cardiac output keeps depressing. Because cardiac output has decreased more and more, you're going to see more depression in mean arterial pressure, and even the blood reaching the tissues, different tissues, for example, the liver. So the blood reaching the liver also decreases. When blood reaching the liver decreases, what's going to happen? The liver cells don't have nutrients, they're going to start dying out. They're not going ischemia, hypoxia changes. So what's happening? The heart is going to, the different they are what we call the sodium potassium pump. This pump uses ATP because of depletion of energy is going down. Okay, we don't have oxygen for synthesis of this. What is going to happen? You're going to have the sodium potassium pump is depressed, okay, or destroyed. Okay, then you're going to have, this happens in most of the tissues. Then you're going to have the mitochondria is supposed to synthesize energy for this kind of pumps. The mitochondria are also dying out, and usually the main reason is because of what we call the lysosomes. The lysosomes are also, they start to die out. They start to release their contents, and when they release their contents, they usually contain hydrolytic enzyme or hydrolases. And this enzyme, what do? They're going to digest the cellular contents. So they're going to cause a process called autolysis. Okay, so it's cellular digestion. But remember also the sodium potassium pump, what does it do? As it is working, because when it fails, you're going to have a lot of sodium retained inside. When sodium retains, water follows. The cells enlarge and the cells start bursting. So this is when you get into a state where we start seeing multi-organ failure. You see most of patients of shock, terminally start getting the multi-organ failure. Okay, you start seeing the liver failing, the kidney failing, and the rest, the pattern increases. Okay, so you're seeing with this initial decrease in blood pressure is continuously causing a vicious cycle. More and more, the more blood volume decrease, and then we get in cardiac depression, vasomotor tone, or mean arterial pressure is decreasing, and then even the little blood that is there, more and more the heart continues to fail, and this process actually keeps on going on and on. Now, then the last phase, what we call, so this is what's why I call it a vicious cycle. it undergoes a vicious cycle of depression of the body. Okay. Now, in irreversible shock, we said in irreversible shock, usually, no matter the type of remedy or therapy that you give, the chance of recovering this person from shock is actually very minimal. Okay. And why is it minimal? This is the reason. So when a person gets into this irreversible shock, remember mitochondria are dying out, and enzymatic activities are also going low. Then we're going to start having decomposition, okay, or breakdown of these high energy phosphate molecules, okay. Especially you can have the creatine phosphate, and also, of course, the one we know is the ATP. So when these molecules start to decompose, okay, you find out ATP is decomposing to ADP, decomposing to AMP, decomposing to adenosine, okay, in the tissues. Now, the worst case scenario usually happens if this adenosine actually decomposes into form uric acid, okay. So when uric acid, as soon as this uric acid is formed within the tissues and seeps in, or even from the endothelial cells, and we're having accumulation of uric acid. This uric acid, why it's usually a big problem, and is the main reason as to why we get into irreversible shock, is because this can never be converted into adenosine or into the precursor for ATP. Okay, so you get this accumulation of uric acid usually makes it hard for you to, no matter the mechanism, because most of the mechanisms in the body, biochemical or whatever mechanism, they require ATP. So no matter how you try to restore this ATP, you can never, because of accumulation of uric acid, you can never restore this patient back to normal because of accumulation of uric acid, because of a total depletion of ATP or energy. Okay, and so that's why these patients become irreversible. No matter what you do, most of the mechanisms in the body require you to have ATP for them to work or to operate, to regain. The heart needs ATP, all these processes. So when you have depletion of high energy phosphate molecules, boop, it's hard for the person to recover. So that's it about irreversible shock. So we've looked at the 3 stages of shock, the non-progressive or compensated, progressive, and irreversible. And we've looked at each of them. So thank you so much for watching. Remember to subscribe, to share, and like this video. And please keep in. We meet next time. Thank you.